Good evening, and thank you for joining us at the college this evening. It's a real privilege to be joined here by Simon Fleming and Rebecca Harston, and we'll be talking to you today about surgical myth busting for our webinar as part of the National Careers Week seminars at the Royal College of Surgeons. We're often asked as surgeons and as consultants and trainees, what in terms of what we see in the films and the movies is real and what is actually made up. And you'll see lots of different surgeons and doctors portrayed in the media. Actually, what we're here to do today is to try and challenge some of the myths that you see and some of the myths you may have heard of from your senior colleagues and students around you. And some of these questions are the questions that I asked as a trainee, as a junior surgeon, trying to progress through a surgical career. I thought it wasn't a career for people like me. I thought that the work-life balance was all wrong. And really today is a chance for you to talk to trainees and talk to people living that journey right now, and also a little bit of access to a consultant, try and challenge those myths and try and explain them for you. It's a real privilege to be here to answer some of these questions for you. And remember, tonight is for you. It's a chance for you to ask those questions and get the answers to everything that you've always wanted to know, but were afraid to ask. Because the reality is, if there's a question that you want to have answered, someone else probably wants it answered too. So the only principle for tonight really is these questions are your opportunity to have answered. There is no question too small, and we will answer them as quickly and as accurately and as thoroughly as possible. It really is a great privilege to be joined here by Rebecca Harston and Simon Fleming, who are really the stars of the show today. Fantastic speakers with great experience and great advice. Simon leads the way in orthopaedic education and is doing some real brilliant work in qualitative research, trying to look at competence and education and training within the field of orthopaedic surgery. And he's been leading the way in the Hamlet Out campaign to improve the perceptions and the realities of surgery for all of us. Rebecca is part of the groundbreaking Essex Surgical Girls group that have done incredible work producing guidance and a load of fantastic advice about applying for and being successful in core surgical training. And it's a real privilege for me to be sharing a podium with them today. Without any further ado, I'd like to hand you on to Rebecca, who will tell us about her and her journey in surgical training. Thank you.
Thank you. So my name is Rebecca Harston. I am originally from Sweden. I moved here for my F1, F2, which I did up in Essex in Basildon. I'm currently doing CT1 at King's College, doing a max fax rotation, having lots of fun. It's really interesting specialty. However, want to aim for a career in plastic surgery, so that's my end goal, getting a trained marine. I have been hooked on having a surgical career since 4th year of medical school, so it's been quite some time now. On this picture here, you see me and my fellow colleagues in Essex Surgical Girls, which we created during my foundation years in Basildon with our mentor, Andrew, who is a vascular registrar currently at Royal Free, mentoring us. So I thought I'd just take the opportunity to discuss a few things that has been asked to me by my junior colleague or medical students that I've been seeing or mentoring over the years that I've been here. The first one is, it takes so many years to become an independent surgeon, is it worth it? And first of all, it's quite difficult for me to answer that because I'm just in the beginning of having a beginning of my surgical career, but I'm having lots of fun, and I think that a lot of people who are about to embark on their surgical journey knows that it takes a lot of years, and that's something that everybody should be prepared for. However, I think it's quite a positive thing rather than a negative thing, because I think it's a blessing to be able to have a job where you can develop and take the next step and take the next step all the time, instead of having finalized your journey after 3 years, because the progression is actually something really wonderful, something positive instead of something negative. So the fact that it takes so many years is rather something positive than negative. Old school surgeons can be sexist. Have you ever experienced that? I have not experienced it myself. I have lots of girlfriends that has experienced that, however. I do not think that this is something that is exclusive to surgery. I do not think that there is only sexism that exists in the surgical field. I think it exists in all medical fields, to be honest, and even outside medicine. It seems like you work all the time. Do you have time for a social life? Yes, we do work a lot. We do stay late sometimes, and I think that's part of the job, and I think that's part of the commitment that you do. However, it is a lot of great fun. The journey is amazing, and but yes, you do have time for a social life. And the last question is, to get a decent job, you seem to need to have it all: publications, extra degrees, presentations, and a lot of audits. Is this true? This is a question that I've gotten a lot because I was lucky enough to get a London job, which was on top of my list. And when I applied for my CT1, I did not have any publications, did not have any extra degrees except for my primary medical degree. And so I'm a living example that it's actually possible. You don't have to have a portfolio that weighs 3 kilos to be able to get a decent job. That's not correct. And this is just some statistic that I've actually borrowed from the Royal College, just to see that we are actually progressing in terms of female male, how do you call it?
The demographics.
The demographics. Thank you, Simon. About 30 years ago, there was 3% female consultants, and just last year there's 13. I think that's quite a good progression. And the bottom picture is also representing females in surgery, but on a training level, in which we are also progressing, which I think is really nice to know, and it's quite encouraging. And this is just a collection of female encouragement. It's organizations, conferences, courses, unities of where females are encouraged to participate, submit papers, discuss, get together, take place in the surgical atmosphere. And I think that's really great. And there are even more coming as we speak. So I think the main reason why I'm here today is because I'm part of something that I'm really, really proud of, and that is Essex Surgical Girls. And it was founded actually by my vascular registrar, Andrew Busutil, when we were at the end of F1. We were just about to start an F2, starting prepared to apply to core training. And we got a message from Andrew saying, "Hey girls, I'm actually mentoring all 5 of you. Why not get together and make a group out of this and help each other?" We started off as 5 girls, and we are about 20 now. And the main idea of the group is that we support each other instead of compete with each other and cut each other's throat. We have done quite a lot of things since we started, and here's a list of things that we've done. We've done preparation courses. We've done a PDF guide on how to apply to core surgical training. It's actually been downloaded from our website over 100 times. We have a poster that we've accepted for ACID. We've submitted that as a cohort for Essex Surgical Girls. We have prepared study groups for MRCS exams, which we have all passed, by the way. We have been invited to do medical talks, and we're all mentoring each other. And on the right, you can see our contact details. You're more than welcome to follow us, and we're trying to keep update on social media. My last quote is just a quote that I heard from actually Royal College seminar that I attended 2 years ago on a completely different topic about trauma surgery. And there was a gentleman who said, there is a difference between fatigue and burnout. Fatigue is what happens when you work long hours and feeling tired. Burnout is what happens due to lack of fulfillment and boredom. You don't get burnout in this line of work. And I think that is spot on how I feel about surgical training and why I chose to do it. I'm going to hand over to my colleague, Simon.
I'm going to try and follow on from Rebecca's talk. So my name is Simon. I'm an orthopedic registrar, and in my spare time I do work around kind of culture change and medical education, and to try to make things a little bit better. So I thought I would try and challenge some of the myths that are out there. The first one is that it is that boys club. It is that a bunch of primarily old white heterosexual men telling everyone how things should be and so on. And that certainly used to be the case, and it is still in certain pockets, but it's something that's very much being challenged. And the culture of manels and the culture of a lack of diversity is not only something that is changing kind of organically, some people would argue tectonically, but it is something that is being consciously challenged. And when you go into surgical rooms now, surgical teams, I think we all start to notice that they're looking more diverse, they're acting more diverse, and we're starting to see that great diversity of thought, which by definition leads to change because people start to challenge, the status quo. there's this attitude that you have to be a big, burly, public school white guy to be a surgeon. Where you went to school and what kind of genitals you have shouldn't dictate whether or not you can be a surgeon. The kind of people we're looking for are passionate about the career. They want to help people, they want to fix people, they want to work in teams. And if you are that kind of person, then surgery wants to have you, and surgery wants to engage with you. And those are the kind of people we want to work in our teams. And again, the more diverse the team, we know the better outcomes they get. One of the fantastic things that we're starting to get now is we recognize that imposter syndrome is a real thing. Many people, more females than male, have this voice in their head that says you're a fake, you're a fraud, you're not good enough, you shouldn't be here, you shouldn't be doing what you are doing. And what we've recognized now is that there is a real power, and it's fascinating to hear the work with the Essex Surgical Girls, in building people up, in empowering people, because often that's what holds people back in their career in surgery, is this sort of competitive, perfectionist, cutthroat attitude. And if we empower people, you actually get a better career, you have a better job, and again, your patients get better outcomes. This is one of my favorite pictures. Often one of the things you hear a lot of in surgery is, well, you know, I'm too young and I can't be myself, and you know, I'm just not ready for it. And this is one of my friend's daughters who was told that she could either be a doctor or a princess. You can't be both. And so I kind of had to sit down with her, and I was like, well, you can be whatever you want to be if it makes you happy, and if it's going to bring you joy, then you do you. And so that's a little half a hip replacement I gave her, and she took that into school and informed her teacher that she could be a princess and a surgeon, and that, you know, you don't have to be a certain age to do something. That this culture of infantilization, like, oh, you're only a core trainee or you're only a medical student, is again something we've recognized, that actually anyone of any age can be a leader, and anyone of any age can make a real difference if they're empowered and if they're made to feel like part of the team and like they have something to say. This is one of the big myths, is this idea that to be a surgeon you have to be strong. It's one of the questions I get really often, especially in orthopedics, that there's a physicality to it. I think there's an argument for being physically fit, but that's more to do with some of the stuff you touched on burnout and kind of wellness and well-being. There's an argument that you should try and keep yourself fit and exercise because it's good for you, and it makes the work we do slightly easier and slightly more fun. But in terms of, you know, I can't be a surgeon because I'm not strong enough or tall enough or don't have the physical attributes for it. Nearly all of surgery is about, the technical side is about technique. As most of us can vouch for, it's about technique, and the rest of it is actually about the kind of person you are, which again is not dictated by the color of your skin or where you're from or your gender or your sex. It's just not a case. And it's great to see that surgery is very much getting its head around that and pushing towards a more diverse workforce. This is one of the big myths, which is that surgical training used to be better. In the good old days where we worked more hours and we were able to crack on more, that somehow, you know, the myth is that training nowadays isn't as good, that the end product, what I want to be, what Rebecca wants to be, isn't as good. And what we know is that that's just not the case. The old system was very much an apprenticeship model, which, as you might imagine, has a lot of inherent weaknesses around hierarchy and patriarchy, and it was time-based. And what we now know is that time isn't training, and hierarchy and patriarchy aren't how you produce good surgeons. And what we know now is the more you feel valued, the more you work in a team, and the better quality training you receive makes a much better surgeon than if you've done 1 million operations but you've done them on your own in the middle of the night. And that perception that the good old days were good is created primarily by people who trained during the good old days, and so it's what they know. this feeds into some of the work around burnout, but also again feeds into the wider question of the God complex, the surgeon as being this kind of arrogant, swaggering kind of monstrosity. And one of the things that we've really come to recognize in surgery is that it's okay to make mistakes. That having a culture whereby you learn from your mistakes, and rather than blaming and finger pointing, and you talked about cutthroat again, it's about learning from one's mistakes and learning from one's failures. Because when you meet people who say, "I don't make mistakes," or who like to blame others and finger point, there's a bigger thing at play there about why are they doing that? Why do they feel the need to knock people down rather than build people up? Because actually, if you look at all the people, certainly I admire, both in medicine and outside of medicine, it's just not the way that successful people work. And nearly all of them have made tons of mistakes, and then they have grown and learned from those. So this is kind of the big thing in terms of questions I get, and it's probably related to a lot of the work I do around culture change and around bullying, undermining, and harassment. When I was a medical student, I got asked, would you like to be the best surgeon in the world, or would you like to be the most liked surgeon in the world? Which would you rather be? And even then I said, well, I kind of like to be both, if that's right. And I was told that it wasn't possible. It couldn't be done. You can either be great or you can be liked, but you can't be both. And what we now know for a fact is that they are not mutually exclusive. If you think about the people you want to work with, the people you want to take care of your parents or your friends or yourself, they tend to be good at their job, and they tend to have interpersonal skills. They tend to have emotional intelligence and insight and team working abilities. And what we now know is that the more negative behaviors that are still associated with surgery, when they're allowed to continue and progress, they lead to poorer outcomes. They lead to teams performing less well. And actually, if you are a lovable star, if you are good at your job and you get on with people and you are polite and respectful and diplomatic and, for want of a better word, kind, that leads to a better performing team, which means not only are your patients better, right, which means everyone loves you and your outcomes are great and all the rest, but also you're generally happier in life. That's when you manage to start to have more wellness and you generally have happier people. And so I think that the biggest myth is that surgery is this sort of toxic place, and certainly it used to be, and we have data that shows that. But we have much better data now that tells us that those things are changing, and that organizations like this college, like the Australian College of Surgeons, loads of organizations have recognized that actually that's one of the key things, like an underlying culture change of what it is and what it means to be a surgeon is leading to a much better workplace for all of us. I think we now have some questions.
Well, thank you, Rebecca. Thank you, Simon, for such inspiring talk, particularly to share with us where you've got through for surgical training so far. This evening is for you. We've got loads of time for loads of questions, and we've already had brilliant engagement from a lot of the people on this webinar sending us questions through. So please, if you think of one, send it through in whatever the messaging format you want to use, and we'll try and get through as many of those as we can. And our first question of tonight really addresses some of the work that we do on a day-to-day basis as surgeons. And we've been asked, what is the frequency of having the same surgery? For example, in a month's period, how many different surgical cases might the surgeon have? So I think it will be great to try and answer this from a trainee's point of view, and I'll give you a little bit of a perspective from a consultant's point of view. But perhaps from a core surgical trainee, perhaps you could tell us about the range of cases that you might see and you might need to get experience in.
So I'm currently in Max Fax at the moment, so I'm not in general surgery, and we usually have dedicated lists. We have a week and we have dedicated lists, one list of just salivary glands, and then that whole list is just salivary glands. And then the next day we only do cranioplasties, and that whole day is just cranioplasties. So we usually have on a weekly basis a lot of elective procedures coming backwards and forwards, coming over and over again. the only reoccurring thing that can come on a daily basis is the broken mandibles that we do. And that is a really exciting procedure because it's usually the reg and me who does it. And the reg is usually let us do quite a lot. So it's one of my favorites. But on a weekly basis, we usually rotate quite a lot of elective procedures. So that's probably my answer to that.
And I get the sense that there's a big variation in MACSAT, and I imagine there's in orthopaedic. Can you talk us through a little bit about the variety of cases that you might face as an orthopaedic surgeon? And perhaps one of the things I used to think about is how do you differentiate between emergency operations and planned operations, and how do you plan for either of those?
So I think that's the joy of being a trainee. From the point where you identify as a surgeon, so from core training onwards, you rotate round. So you actually, as a trainee, get to see a lot more variety than a consultant, because once you're a consultant, you've picked your team. And certainly as a trainee orthopedic surgeon, there's often quite a clear delineation between what we would call trauma and general surgery, often call emergencies, and elective work. So in orthopedics, the common traumas are basically broken hips, broken ankles and broken wrists. You see other things, you see infections and more complex cases, but your common ones are often broken hips, which are a huge issue, part of our workload, broken wrists and broken ankles. And then from an elective side, the great bit about orthopedics is that it's broken up by, for want of a better word, body part. So depending on what bit you're rotating through will be the bit that you're fixing. So you might have, like you say, you have your salivary gland list. We might have a day where you do 3 or 4 or 5 or 6 hip replacements or knee replacements or shoulder arthroscopies or what have you. And again, you rotate around all the different bits of the body until you are reasonably comfortable in the generalities of trauma and orthopedics. And it was great to hear you say that you have favorites, because I'm the same. So I have identified that I enjoy hand and wrist surgery. So whether it's trauma or elective work, I absolutely love when I'm doing that sort of intricate stuff. That's the stuff that brings me the most joy. And yeah, so in terms of kind of the variety of surgical cases, it often depends on who you're working for and where you're working, what you're rotating through. But that's part of the fun, is the variety, because you then, as you progress through your training, start to go, well, I like that bit. And it's okay to say, oh, I hate that stuff. I really don't enjoy that kind of surgery. That's not for me. You learn about it for exams and things, but it's okay to start to not super specialize, but have things you prefer and interests. And that's part of the joy as well.
And before we move on to the next question, one of the things that I'm often asked by medical students and junior doctors and even junior surgeons is, do I need to know what type of specialty I want to do? So, for example, when I was a medical student, I didn't know I wanted to be a surgeon, but when I started my surgical training, I wanted to be a cardiac surgeon. But it was my first job with who became my mentor, Mr. Suling, an upper GI surgeon, who made me realise the value and the benefits of upper GI surgery. What do you think? Do you think it's something you have to know from the start, or is it something that you have a taste of as you go through the rotation?
I think that's one of the beauties of having core surgical trainees, because I can only compare it towards how it is in Sweden. In Sweden, you do the equivalence of having a foundation program, and then you go straight into specialization. You don't have the rotating sort of core training kind of employment. You go straight in, and then you keep
like the North American system. You're like an intern, and then you
go straight in. Yeah, and I think that because I didn't decide that I wanted to do plastics 100% until the beginning of CT1. So I chose an uncoupled program, which gave me some time to think. And now I'm completely sure. So I think it's a really good opportunity to get into the surgical field and have some time to think. I think it's a really good thing to be able to rotate around. Because, for example, if you want to do orthopedics, a lot of you guys do plastics rotations as well. So you get a taste of a lot of things as well. And sometimes it can change your mind. You never know.
And as someone involved in education, how would you kind of advise some of our students who are junior doctors? Do you think they need to know now, or?
There's that fine line, isn't there? Because you also have to play the game, which is if you have to know what it's useful to be working towards something. However, we now know that less than 50% of foundation doctors move straight into core training. The F3 year, where people often go and do something medical, but often something else. They might do a medical education fellowship or an anatomy demonstrating fellowship. There is an argument now that there's no rush, and that, again, as you might imagine, it's better that you make the right choice first time than rush into something. The general lived experience for people is very much an amalgam of what you both said, which is you start to rule things out. I'm not a GP, I'm not a physician, right, so I'm a surgeon, I'm more of a surgical person. And then you start to rule things out, and often it's a mixture of people, mentors, inspirational bosses, inspirational nurses, inspirational colleagues, and kind of life-changing experiences. So mine's slightly atypical in that I knew I wanted to be a surgeon probably by my 4th year of medical school. I'd ruled out GP and most of medicine. And then I was in the Royal London during the 7/7 bombings. And it was a major incident, and there was chaos, and well, not chaos, but you know what I mean, like it was all very frantic and what have you. And then I just remember vividly in the corner of the resus department, there was just these 2 or 3 teams that just looked just awesome. They just looked like they had it all under control. They were just making decisions, theatres, plaster room, this, that, and it was basically vascular orthoplastics kind of doing their thing. And I was like, I need to look into those specialties more. Because for me, they literally were fixing people. People were coming in screaming, and 20 minutes later, they were like there in a sling, like, how you doing? So part of the advice I give people is don't be afraid to ask questions, and don't be afraid to be involved. I more and more now get medical students going, can I just come hang out with you for like a week, 2 weeks? And I'm like, sure. What? Like, because you want passionate people, you want keen people. So if you can't decide between 2 or 3 or 4 specialties, whether you're a medical student or a foundation doctor, just don't be afraid to just drop someone an email and be like, can I come see what you do?
My experience was a little bit less dramatic. So I've always wanted to do general surgery until I did a taste a week in Broomfield in their plastics unit, which completely changed everything. And since then, it's only been plastics.
Thank you.
Yeah.
I would absolutely echo that. If you're thinking about doing something, see what it's like, have a taste today, have a taste a week, find people who are keen and inspiring and enthusiastic, and find the best of the specialty, find the best of what it's going to be in that job, and see what that's like. And also look beyond the level that you're at now, look beyond the F2 level or the F1 level, look to see what it's like as a core trainee, look to see what it's like as a senior registrar and beyond, because that's what the reality is like. Now, our next question is a little bit about technologies. We've been asked about how common it is to introduce a new technique and new technologies into a surgical process. So perhaps I'll just ask you a little bit, spend a minute or two talking about some of the new technologies that you've seen during your training. And particularly, one of the things that people often ask about is, if there is a new technology, if the consultants are learning those, how am I going to learn those as a trainee if they're learning them themselves? So perhaps you can answer.
It's an interesting question, because medicine moves far faster than we as human beings can, right? By the time you finish medical school, everything you've learned at medical school is basically out of date. And technology-wise, we're always moving at a fast pace, and actually certain technologies are reasonably easy to introduce, as you might imagine, and some have to go through lots of kind of checks, especially, for example, in my specialty, any sort of implant has to go through huge amounts of checks. But a great example of a technology that's changing the way we think about things is 3D printing. So it makes me sound like an old man, because I'm about to do like, oh, I remember when 3D printing first started, but I do. And when 3D printers were hundreds of thousands of pounds and people thought it was just pie in the sky, kind of, you know, snake oil salesman stuff. But actually now we're getting to the point where we, in orthopedics, 3D print models of fractures and bones, both so that we can visualize them and so we can template them, but also so that we could teach them. So I might 3D print that fractured mandible and go, I'm going to make 4 printouts. Why don't you practice fixing it and show me? And if I'm happy with those, then that could definitely be your case. But also, for example, we do bone cuts and things, and we can 3D print implants and cutting jigs and all that sort of stuff. And 3D printing, robots, augmented and virtual reality, those are all technologies that are slowly being introduced, but of course they have to be backed up by evidence. Otherwise, it's just the fact that we like shiny toys. And so the one thing I quite like about surgery is most surgeons are pragmatists. So if it works and you can prove to me that it works, I'll use it. If it doesn't work or you can't prove to me that it works, then we tend to be quite reticent about it because we need the evidence and our patients expect it to be evidence-based.
I remember the first time I came across a 3D printer was on Grey's Anatomy a few years ago. And I thought, this is ridiculous. I thought it was ridiculous. And then all of a sudden, here it is in real life. Have you come across in your training so far some new technologies that you'd like to have the chance to use and develop on in the future?
I was in a conference in December run by the Royal Society of Medicine, where they were discussing a plastics conference, where they were discussing their regenerative characteristics of fat and how we can use that in, for example, if they have for after cranioplasty, if they have a temporal hollowing, that you can fill it with fat and that it can actually grow. And that there's lots of research going on within that, and I think that's quite exciting to know, because there's lots of research going on around fat and how we can use that to grow new tissue. Yeah, it's really interesting.
And I think that's right. One of the key things about a surgical career is there are few careers, I think, within medicine where you get such development of technologies and such interest and expertise to try and develop those for patients.
Yeah.
And a lot of the kidney is never going to work in a different way. It's worked like it done for a million years. But how you might operate on the kidney, or you might fix the kidney, can change all the time. And it's a really exciting field of the medical world to be in. Our next question has come through, and it's talking about gender differences within surgery, which is real, and as Simon's talked about already, is changing, and a living example of that is Rebecca and all the great work that they've been doing with Essex Surgical Girls. We've been asked if there's an inequality regarding men's and women's salaries, and interestingly, whether hospitals or patients prefer one gender over another, and if so, what some of the reasons might be. I think it'd be nice to know what you thought and what your experience has been as a core trainee, and Sam as yours as a senior trainee. Certainly from my point of view, I think it's really important that we talked about before the webinar started was actually what I think might be your experience is very different to what you actually see as your experience. And so if you feel something, don't let yourself be persuaded that it's not there. Address it, improve it, and it will get better. I'd very much like to hear your thoughts about it, but not just gender, but all sorts of lack of diversity within the surgical workplace.
Regarding salary, I cannot really comment on a lot because I spoke about this with Simon before. Being a CT1, you cannot really negotiate your salary. We all have a standardized pay, or I thought. So I have never really given it so much thought. I always thought that everybody had the same standardized training salary. So I don't have so much to say about that. I didn't know there was any differences at my level, at least. And if hospitals or patients prefer men over women, I think a lot of surgical teams that I've worked in has had more men in them than females, so it could be misinterpreted as that they would prefer a man over a woman, but I don't think they do. The MaxFlex team I'm working currently has more than half of the consultants are actually female. They're really, really good. So I don't think that there is that the patients would prefer a man over a woman. It's just that they are more men. And they take what they get.
So there is a gender pay gap in the United Kingdom. There is a gender pay gap in healthcare. Depending on the specialty and the level, it varies between about 17% in terms of men earning about 17% more than women to the 30% range in general practice, for example. If you're interested in it, Google gender pay gap Jane Dacre, who is the ex-president of the Royal College of Physicians, who was leading on this work nationally. And that gender pay gap is very complex. So it's actually very easy to think that if there's standardized pay, there is no gender pay gap, but it doesn't take into account less than full-time training, pregnancy, divorce, the fact that there are societal pressures, which mean, for example, you see less women in higher influence, higher pay positions, ergo women are earning less. And these are all things, again, that are being worked on and studied so we can understand them more and better and therefore improve things. In terms of the the question, do hospital patients prefer men surgeons over women surgeons? To kind of build on what Rebecca talked about, there's some interesting work at the moment about a patient's right to request a surgeon from a certain group. And what it comes down to is, I think we all have to recognise that there are certain conditions, examinations, whereby I don't think it would be unreasonable for Rebecca to request a female physician, or for me to request a male physician. However, outside of very specific contexts, I loved what you said about, you take what you get. I think, especially outside of an emergency situation, whereby certain behaviours either can be excused or at least understood because of emotions being high, and sometimes, for example, if you're septic or if you have a mental health condition, it is understandable that you may say or express views that might be perceived as sexist, racist, homophobic, or what have you. But otherwise, if you come into hospital and you request a white doctor or a male doctor for an elective, a non-emergency, a non-acute thing, I think Rebecca's absolutely right. I think the answer is no, the NHS is not a place where we support those sort of opinions, and we are a diverse healthcare team, and you get what you want. And actually, I'm quite proud to work in an environment where I think if someone was expressing those views, I think now someone would challenge them. Someone would say, actually, that view is sexist, and Miss X or Professor Y is actually the best in her field, and if you're not happy with her treatment, then do feel free to find another hospital.
And I think that's really important, certainly as a trainer now. If ever a trainee came to me with this kind of issue, it would be so important that rather than brush it under the carpet or make it work, it's important that you support the trainee. And not just support a trainee, a colleague, a peer, if a consultant came to me and said this had happened to me, it's important that as an organisation, as a healthcare service, as a college, we support the importance of diversity and equality through our provision of surgical healthcare.
Absolutely.
You can imagine that was one of the more commonest questions that we can get. And please, we're very happy to explore this further if you wish to later on in the evening. We've also been asked our next question, which is whether or not it's possible to combine a career in surgery and a career in research. And actually, it's funny to hear the question asked in this way, because another way the question is asked about research, and has been a bit later on, is do you have to do research to become a surgeon? So these are kind of the two things that are often asked about academic research in a surgical career. So perhaps, Simon, particularly with the work that you're doing at the moment, if you could start by telling us what you're doing, how it's different to a normal orthopaedic career, and also whether or not you think it brings benefits to your career and whether or not you have to do it.
Yeah, so I am doing what's called an OOPR, which stands for Out of Programme for Research. So I'm an orthopaedic trainee, and I have paused my orthopaedic training to take 3 years out to do a PhD, and I'm doing my PhD in medical education. I'm doing it for a variety of reasons. I want to work in more academic units, but more than anything, it's because it's a subject I'm passionate about, and so I just wanted to know more about it. And it sounds weird because you obviously don't have to do a PhD to open a book. Like, it's okay to just read. But I wanted to really get into it. I wanted to mix with people who felt the same way, which meant I wanted to go to conferences. And then if you want to be having really in-depth debates, you need that credibility and that driver to read and be part of that community. It is absolutely possible to do a career and have a career in surgery and a career in research. And actually, there's loads of different routes in. So you can be an academic foundation doctor, you can be an academic core trainee, you can be an academic registrar, and you can enter those at different routes. So I was not academic foundation, I was not academic core, and I am not an academic orthopedic registrar. I identified a thing I was passionate about and took time out of my training to do that. Now, in terms of whether you have to do research, the answer is basically yes. There are certain things you have to do throughout your training to demonstrate that you understand science. And that's really the point, is we're meant to be surgeon scientists, not in any way that it doesn't mean everyone has to go sit in a science lab, but you need to be able to read a paper, understand the science, and have that debate. So if we were colleagues and you say, I do X, I should be able to say, well, I do Y, and then we should be able to have an informed debate that isn't because I say so, but, well, there's this evidence and there's that paper, and we've both attended this conference and that conference, and we owe it to our patients to produce good science. So most trainees have to do audit and research. One of my friends used to say the difference between audit and research is research is what song should we be singing, and audit is always singing the song right. And so we have to kind of be involved in both, but mostly it's about to demonstrate that you understand it. So it doesn't mean that everyone has to do a master's or a PhD. That's just not the case. But everyone has to do some projects and be involved in science at some level, just so you have an understanding of the process. And so that as your career progresses, when someone goes, I'm going to do a different operation because I read this paper, you can read the paper and go, yeah, that makes sense, I'm going to change my practice. Or, actually, mate, I don't know if you read this paper, but they only had one patient in it, and it was funded by the company who make the equipment. And you go, oh, right, all right, and I'll just... and so, yeah, I think it's absolutely possible, and lots of trainees do it.
And if I can just say something, I feel like you don't have to, as Simon did, leave training temporarily. I'm starting a master's degree in September, and I'm planning to do it while I am working, so I'm going to do it part-time over 2 years. So that's my way of doing research and working in surgery at the same time. So you can do different ways.
Flexible training is increasingly the way forward. There's so many different ways of...
And do you think research is going to be, or some of those skills and attributes are going to be important for your higher plastic surgical applications in the future?
Yes, definitely. I'm actually really excited about the part that I'm going to learn. I haven't really done a lot of research, I haven't done a lot of academic training, to be honest. So I'm actually really excited to learn, and the topic is something I really think is interesting. So I'm excited to start, and I think I agree with Simon. I think it's quite important to have that a little bit in your package when you apply for higher training.
So our next question, are you able to juggle a family life or small child during core training? Is it fairly common? You can imagine the issue of raising a family, some of the issues about work-life balance are really common questions that we're asked as surgeons and as a surgical profession. And I think we'll address this question in a couple of ways. We'll talk about the issues of work-life balance, which Rebecca's already touched upon. So we'll talk a little bit about how you juggle a social life and how you juggle the things outside work that are important to you. We'll also talk a little bit about how we've seen some of our colleagues with families juggle training, and perhaps that'll be our way into this question. So Rebecca, you've talked a little bit about social life and work-life balance already. What are your experiences?
So I'm in a bit of a special situation because I have my family outside of this country, so it's not like I can see them on weekends or on evenings like that. So when I see my family, I usually go home for a week and then come back. So it becomes a bit of a different situation compared to someone who may live in the country and see their family on a more regular basis. But I have friends and I have a partner, and I manage to see them just as much as I think anyone else in a medical or in GP. So I have actually no problem with it, even though sometimes he has to see me study sometimes when he's cooking, but that's just part of it.
What about you, Sam? What have you seen through training?
So I talk more now about work-life integration than work-life balance, because I've come to accept that I often don't have balance. And that sounds unhealthy, and I say that like with my hands held up, saying I recognize that sometimes I get the balance wrong. But it is possible to integrate them and find that happy halfway house, so that you say, look, I've got an exam to revise for, so you know what? The balance for the next 6 months is going to be like that. And that's just how it is. But then I'm going to book a holiday and I'm going to get back to the gym and I'm going to do this, that, and the other. But for example, I'm doing my PhD and I'm very aware that it can be quite sedentary and quite socially isolating. So I've had to make an effort to, again, integrate that work. So whether it's making sure that I just walk places rather than get Ubers, or go to the gym a bit more often, trying to integrate those things. And it can be a challenge and we don't always get it right. In terms of the the family life stuff, I mean, being a surgical trainee is tough on home. And I know from which I speak, like, even if you communicate really well and are really organized, it can be very tough. Saying that, and I'm now doing that thing where I speak on behalf of people, but only because I am privileged enough to know these stories, is it is possible to have a family. I don't have children yet, but it is possible to have a family and be a successful surgical trainee. Fact. Less than full-time training is supported and should be supported throughout your training, and how that's delivered is up to the region and what have you. But if you look at a region like Wessex, for example, so the Southampton, Portsmouth region, their orthopedic rotation is 50-50 male-female, a number of whom have children, many of whom are less than full-time. It is possible, and if you are supported, it is not just possible, but kind of, you know, enjoyable and not stressful at all. Are there horror stories of people who have struggled both in their relationships and with their family life? Yes. Are there horror stories of regions that are less supportive? Yes. But those are now becoming the exception rather than the rule. And actually, lots of my colleagues have healthy, happy family lives and children and are doing very well in their training. Thank you very much. So, and this college in particular has made kind of flexible working and less than full-time training very much one of their kind of key indicators for, you know, something they want to work on.
I absolutely echo everything that you said, and certainly in my region in Yorkshire, the importance of supporting less than full-time training, but not only supporting it but encouraging it, taking away some of the things that have historically been commented about less than full-time training. A little bit earlier in your talk, Simon, you talked about not wanting to, why do you have to choose between being a nice person, being a good surgeon? Equally, I don't think we should have to choose between being a great mum or dad and being a great surgeon. It's possible to do both, and it is the job of the profession to make sure that that is possible for all of us who want to do this career. I do have a young family, and I have to say I would not have been able to do my career without my wife supporting me. And equally, my colleagues, male or female, within surgical training are very well supported by the people around them, friends, family, whoever it may be. But equally, my job as a trainer, my job is that it's absolutely crucial as a deanery in Yorkshire, as a hospital in Huddersfield, we support our trainees to make sure they are happy and are able to enjoy both absolutely critical, crucial parts of their life. Our next question comes through about timing and about how quickly you progress through surgical training. And historically in the past, there used to be a stigma about taking time out after foundation year training. We've been asked whether or not there is still a stigma before applying to core training. Is it still the case, and will it harm my core training application? We're lucky to have an expert on core surgical training application. So perhaps you could tell us a little bit about the rules, first of all, for eligibility, and then whether or not you feel there's a stigma around taking some time out.
A lot of my friends did take a year out, and I think it could be a good idea to have a break. You will, given the rules of, you know, annual leave and study leave, there's never going to be an opportunity again, unless you take a break between core training and ST3, where you can take a longer break if you want to do something else that's outside of training. I do know that for the plastic, because I've looked into the plastic ST3 application, and I do know that they, if you've had a certain amount of years after your graduation from med school to the day that you apply to your ST3, they do penalise you. But I think that people put too much emphasis on that. It's a tiny percentage that they deduct from your portfolio, and I don't think it actually matters, because most people do take a year off. I'm planning on doing CT3, for example. A lot of people is doing an F3, and I think, to be honest, if you're not sure what you want to do, or is not willing to take a job maybe in a certain region, or want to be in a specific field, I think it's better to take F3. And I've actually never heard any F3 saying that they regret the decision of doing it. They're always saying that they're happy that they did it.
Simon, you've met a lot of consultant trainers as part of your PhD. What do you think they would say, and what do you think you feel about taking some time?
I think Rebecca hit the nail on the head. You're doing a CT3, I did a CT3, and we have data. We know that the majority now of people do an F3. So the stigma isn't really there anymore, and the stigma that you do encounter comes from, I think, a lack of understanding of how the system works, how applications work, how selection works, and if I'm honest, a little bit of jealousy, because I did a CT3, but I also did a year in Australia, and I've got mates now who are like, well, it's not fair, you've got to have a year in Australia. And it's like, no one stopped you from getting to Australia. Like, you just didn't go. I got a tan. Like, it was great. I was an orthopedic registrar in Australia. I still worked and operated. I just went scuba diving every weekend. It was great, but I still worked. I still did projects and all the rest. And that's the thing. So it doesn't harm your application. I think part of it is about what you do with your year. If you take a year out and you take a gap year and you go walk around, whatever, that's actually fine. But you have to be willing to accept that at some point someone's going to say, what did you do during your F3? And if you say, well, I've walked around Nepal for a year, but I have an interest in rural and austere medicine and all the rest, they're going to be like, that's amazing. I've got lots of friends who do 6 or 8 months medicine or what have you, and then travel. I've got friends who do F3s in their area of interest. So they might go and do, say, something in plastics or spines or peds or what have you. And we know that that's really, really common. If I had done nothing but the straight and narrow, I'd have been a consultant 6 years ago. I'm perfectly happy with the life I've lived and the experiences I've had. And I think my life has been richer for it. I think my CV is certainly richer for it. And I think I'll be a better consultant colleague for it as well.
As one of my colleagues, one of the founding members actually of Essex Surgical Girls, she still wanted to be a peds surgeon, and we finished F2 at the same time, and she decided to take an F3 and work at Gosh, and got a great job there. And now, thanks to having that year in Gosh, she now got a pediatric surgery themed CT1 job, and she would never have gotten that job unless she had this year in Gosh. So I think it was a really good investment. So it doesn't have to be a chill traveling year. It could be something that you invest in your career.
So it can really add value.
So I think in summary, I absolutely echo all of these comments that there really is no stigma anymore. And if you want to do something, it's much more about what you do and get opposed to a job that's supported. Many hospitals now have formal F3 posts which are there to develop your career and allow you to do the things that you want to do. This placement at Great Ormond Street sounds incredible, and some of these opportunities in life. And as a consultant, I can tell you the hardest part of the work isn't the operations anymore. It's about the maturity and experience to deal with the things that come in through the door. Some of the emotional and some of the physical challenge that you face. Being that year older, having seen a few more things in life, makes it much easier to deal with those things when they come in through the door. And I would absolutely echo what both of you have said, really, about taking the time, being sure that this is the right thing for you, and being as strong and confident as you can be to do the job that's ahead of you, not just getting into it. So our next question, I'm a medical student and I'm so obsessed with surgery. I struggle with anatomy in years 1 and 2. And it's the only thing that makes me worried about being a surgeon. Do you think I can or should apply? Well, as someone, before we go to our panel, who failed their anatomy exams at university early on, you can absolutely do this and carry on. So yes, the college will support you. But so let me ask our panel, tell me about your interest in anatomy.
I failed my first anatomy exam. So,
seems to be a common theme.
but I'm still here, so definitely. You will learn anatomy over and over again because you're going to do your MRCS exams, you're going to do, we have anatomy teaching and core training, it's going to be Part B. So you're going to go through anatomy over and over, you're going to forget it and then you're going to remember it again, and it's going to be a constant process of renewing your knowledge, so you have to worry about it.
For me, I think the difference is the more clinical my life became, the more relevant the anatomy became. So I struggled with anatomy at medical school, and partly it was just because it was this abstract thing. Learn this because it'll be in the exam. Oh, okay, fine. And then it was learn this because this will be in patients. And you're like, okay, I guess that's important. And then it was learn this because you're doing an operation in a week's time or a month's time. And you're like, I'm going to learn this now. And actually, I am the same. Even now, I find the anatomy, it sounds awful, the anatomy I care about is easier to learn. For my orthopedic exams, I will need to revise the anatomy of the whole body, and I will struggle with some bits because they're bits that I'm not as interested in. I know that to be true, but it shouldn't stop you applying. And actually, this is a really great question because this shows insight. You, whoever you are, have recognized an area of weakness. So I'd much rather a medical student come up to me and go, Simon, I'm really struggling with my anatomy. Can you help me with this? Or how do you remember that? Great, wonderful, because it's difficult. Like knowing that there's something that you're struggling with is the first step to smashing it out of the park.
Absolutely, and I think if you think it's right for you, then an anatomy exam in itself isn't a reason not to go for it. Really interesting question towards we get toward the end of our webinar. And this, I think, really goes to the heart of what life used to be like and what it's like now. And the question is, I've seen some of my more senior colleagues have to do procedures that have not much experience in. And sometimes it's difficult for them to speak out because they don't want to lose the opportunity. How do you advise navigating these kinds of situations that you don't feel confident in without losing the training opportunity? It's a fantastic question. And Rebecca, perhaps we talked a little bit earlier before the webinar about opportunities for operations. Could you tell us how you might approach this situation?
So for example, in MaxFlex, when I entered that job, I had zero experience of anything in this area. And I had to study and revise a lot, and everything was new to me. The anatomy was new to me, the technique was new to me. So I was a baby, and I was lucky enough. I had really, really good registrars, and I've always said to them, I'm new to this, and you need to help me. And actually, maybe it's a unique case, but they've actually been really helpful, and they've always stayed with me. Even if it's a simple abscess in the face, they've stayed with me if I needed them. And even if they're not doing anything, if they're just here for my comfort, I think that's enough just to make sure that I'm doing the right thing. And simply just asked for help.
And I think hearing that tells you how great the King's MaxFlex unit is, because that's a really positive story to hear about training. Sam, what do you think about
this? To me, sounds like the things we've touched on. It's a mixture of imposter syndrome and a fear of asking for help. And actually, I think it's normal to be like, well, I'm not an expert in this, maybe I shouldn't. And it's normal to be scared and nervous and apprehensive, even if you've prepared and read and everything else. And again, I think a lot of that fear comes from a fear that that opportunity will be taken away from them. But actually, maybe in the past that was the case, you know, unless you swaggered in and were a bit of a cowboy, those opportunities were taken away from you. But now, training and the culture of training has changed such that I think one of the ways we can overcome that fear of asking for help and that imposter syndrome is just encouraging people to say, you know what, boss, I've read the book, I've read the papers, I've gone to the sim lab, I'd still like some help, some support. I'd like you, you know, I'm a senior trainee, but I still say to my consultant all the time, I'd like you in the corner of the room. I'd like you scrubbed in, but could you, and I think my experience has been that most trainers appreciate that. And I think patients would appreciate that too. And I think a lot of that fear comes from again, a perception that you won't be allowed to play. And actually, if you just say, look, I just need a bit of help or a bit of support or a bit of guidance, the majority of trainers will be like, wow, what a great trainer. They know their limitations, they know what they're good at, they know what they're bad at. And if you're great and you think you're not, a good trainer will lift you up. And if you're okay but need some encouragement, they'll do that too. And equally, if you're a bit of a cowboy, a good trainer will rein you back in again. And that's why we need trainees to speak up about this stuff.
And I agree, as a trainer, in answer to the question as well, honesty. What can you do? What can't you do? Be honest, and we will teach you. That's our job. It's our job to look after the patients, and it's our job, secondary to that, to train you. Be honest. And really, in this day and age, no one should mind where you are. We're coming towards the end of our webinar, and I wanted to just highlight a couple of upcoming webinars the college has. It's a really great organisation to be a member of. We're privileged to be part of the College of Surgeons and really promote some of the great things they're doing for surgery and surgeons, and ultimately our patients. Our webinar programme covers a range of topics, and you can please look at the programme online and visit the calendar on rcs.ac.uk/webinars, and there are webinars coming up for consent and audits and the future of surgery and many, many more. We've also got some fantastic events coming up through 2020, very similar to events like this, which will be a much bigger event to boost your portfolio, tips to prepare for the exam. There'll be events in London and Brighton and Newcastle through the year about wanting to be a surgeon and how to develop that surgical career. And also, once you get into the surgical career, how do you stay well? Wellbeing in the workplace events planned in May in Cambridge and in Birmingham in September. So again, look at our rcs.ac.uk/events page to look at some of those. There are also some fantastic opportunities for medical students. Tell your colleagues, apply for these yourself. We have Margaret Wick Education Bursary for a chance to win up to £1,000 to attend an RCS course. There are Ethicon Foundation travel grants, and the closing date is coming up in the middle of March. We've got a number of elective grants to support you as you progress through your medical school training. The Royal College of Surgeons and affiliate membership, very proud to support some of these initiatives for our medical students. And if you're not a member, join. There are so many things, and I have to tell you, even if you don't want to be a surgeon, if you're progressing through medical school, for the value that you get from affiliate membership at the college, the number of things available to you to support you through medical school, through training and through a career, no matter what you do, for I think it's £15 a year, for what you get for that, it is unbelievable. And the college, as Simon and Rebecca have already kind of highlighted today, is really leading the way on stress and burnout and progressing through training, no matter what career specialty you want to go into. So I can't advocate enough the benefits of affiliate membership, and I'd encourage you to join. It leaves me finally to tell you about some of the important social media and web pages that you can follow us through. In addition to all of these, I want to highlight once again the social media pages of Simon and of the Ethics Surgical Girls. And that kind of leads me nicely on to say thank you once again for being such a brilliant panel, giving up your time this evening to talk to our students and our junior doctors and to talk to our surgeons of the future. On behalf of the college and of me, thank you very, very much.
Thank you.
And thank you for joining us.